You know that feeling, right? That sort of stubborn burn after maybe indulging a bit.
Yeah, we've all been there.
Most times it's just, indigestion. But if it's happening a lot, you might hear the term Barrett's esophagus pop up.
Mm-hmm.
Now, straight away, the really big takeaway here is this. Loads of people get heartburn sometimes, and almost none of them will ever develop Barrett's.
That's absolutely the key thing to keep in mind. So today, we're really digging into Barrett's esophagus. We're using those MSRA revision notes as our guide.
Right.
And our goal is basically to pull out the most important stuff, the things you really, really need to remember for your exams, and hopefully explain it all clearly, make it stick.
Exactly. Think of this as your express route to getting a solid grip on it.
Okay.
So let's start at the beginning. What exactly is Barrett's esophagus?
Okay, simply put, it's a change. A change in the type of cells that line your esophagus. You know, that tube running from your mouth down to your stomach. And this change, it often happens in people who've had GARDS, that's gastro-oesophageal reflux disease, for a long time.
Right, the chronic reflux.
And here's the interesting bit. This new lining, it starts to look a lot like the lining you find inside your intestine.
Huh. So it's almost like the body's trying to adapt
Yeah.
to cope with all that acid splashing up.
That's a great way to think about it, yeah. It's like it's trying to put down a tougher carpet, so to speak.
Okay. And why is this so significant for MSRA revision? Why do we need to know about it?
Well, because while Barrett's itself isn't cancer, the crucial point is that it does significantly increase the risk of developing a specific type of cancer called esophageal adenocarcinoma.
Significantly.
We're talking something like a 50 to 100-fold increase in risk. Now, that sounds quite dramatic, I know.
Yeah, it does.
But what we want to do in this deep dive is give you the full picture, the context, so you understand what that increased risk actually means in practice for patients and for your exams.
Precisely. We're going to unpack it all for your MSRA. We'll cover the definition, the causes, who's more at risk.
Yeah, how it develops, what else it could be the differentials.
Who gets it, how it shows up, diagnosis, management.
Prognosis, complications, the works.
Right. So let's start with that fundamental question again. What is Barrett's esophagus, technically speaking?
Okay, so technically, Barrett's esophagus is this transformation. The normal lining of the esophagus, which is made of squamous cells, think of them as sort of flat tile-like cells, gets replaced by columnar epithelium.
Columnar.
Yeah, taller cells, more glandular, and they look a lot like the cells lining the intestine. And like we said, it's very strongly linked to long-standing GORD, that chronic reflux.
Okay, so the core is this switch-in cell type, driven by the reflux. But what's the sort of official confirmation, the diagnostic stamp?
The definitive diagnosis really comes down to finding intestinal metaplasia. That specific change to intestinal-like tissue has to be seen in biopsies.
Biopsies taken during.
During an endoscopy of the esophagus, exactly.
Right.
And for exam purposes, it's useful to remember the subdivisions based on length. Short segment Barrett's is less than 3 centimeters long,
Okay.
whereas long segment is 3 centimeters or more.
Got it. So it's not just any change. It has to be specifically those intestinal-type cells confirmed on biopsy.
Right.
Now, let's think about what kicks this all off. The cause, the etiology.
The main driver, as we've kind of touched on already, is chronic GORD, chronic gastro-oesophageal reflux disease.
Right.
Just picture it.
The lining of the esophagus, it's quite delicate, really. It's just not designed to handle highly acidic stuff from the stomach, or sometimes bile as well. And repeated exposure to this harsh environment causes ongoing irritation, ongoing damage.
Like a sort of constant chemical irritation almost.
Exactly. That's a good way to put it. And over time, this repeated injury can trigger those cellular changes we talked about, the metaplasia, the development of Barrett's.
Now, while we're pretty sure GORD is the major player, the precise molecular steps, the pathways that cause this switch from squamous to columnar cells, well, they aren't completely understood yet.
Ah, okay. Still some unknowns there.
Definitely. It's still an active area of research, which, might just pop up in future exams if they're looking for that cutting-edge knowledge.
Good point. So chronic reflux is the main cause, but the exact how is still being worked out.
Yeah.
Now, who is more likely to get this? Who's more susceptible?
Yeah.
What are the key risk factors we need for revision?
Right. Risk factors. A mnemonic can be really helpful here. Let's try using GO race.
Go race. Okay, sounds catchy, exam friendly. Break it down for us.
Okay. G is for chronic GORD. That's the big one, the foundation.
Right.
O is for obesity. More abdominal pressure means more reflux. Makes sense. R is for race, specifically being male and of Caucasian ethnicity. That carries a higher risk.
Yeah.
R covers age, being over 50, and also family history of Barrett's or esophageal cancer. C is for cigarettes, smoking, linked to increased reflux and damage.
Makes sense.
And finally, E stands for existing esophageal issues. Things like previous esophagitis, a hiatus hernia where part of the stomach pushes up,
Yeah.
ulcers or strictures, those narrowings of the esophagus.
That's really helpful. Go race. Okay. What about alcohol? You often hear about alcohol and reflux.
That's a good point, and worth clarifying for exams. Alcohol is linked to a higher risk of GORD and also generally to esophageal cancer risk.
Nice.
But it's not usually considered an independent risk factor specifically for developing Barrett's itself. Its effect seems to be more indirect through worsening the reflux.
Okay, that's a really important distinction. One of those things that could potentially trip you up in a question.
Exactly.
Now, what if someone already has Barrett's? What increases the chance of it progressing, turning into adenocarcinoma? Are the risk factors different then?
Yes, there are some factors that definitely heighten the risk of progression once Barrett's is established. Again, being male and older age are significant factors. Then, looking at the Barrett's itself, having a longer segment. Now, interestingly, our notes mention greater than 8 centimeters here.
Oh, wait, didn't we just say long segment was over 3 centimeters?
We did, and that's a potential nuance for exams. The definition of long segment is 3 centimeters, but for progression risk, some sources highlight segments over 8 centimeters as particularly concerning. Worth noting that potential discrepancy.
Right, good flag. Okay, so length matters. What else?
The presence of dysplasia, that's abnormal cell growth, a precancerous change. Also, any visible mucosal damage seen during the endoscopy. And, crucially, continued poorly controlled reflux.
Still driving it.
Still driving it. Plus, a longer history of GORD symptoms, starting greedy at an earlier age, and again, a family history of esophageal adenocarcinoma. All push the risk up.
Okay, that's useful. Knowing the red flags within the Barrett's group.
Yeah.
So we know it's at risk. Let's get into the pathophysiology. How does this cell switch actually happen?
Right. Think of it like a sequence of events, all kicked off by that chronic reflux. Step 1. Constant acid and maybe bile splashes onto the esophageal lining. That causes persistent irritation. Step 2. This ongoing irritation leads to inflammation and damage to the normal squamous cells.
Right.
Step 3, as a kind of protective response, the body starts replacing these damaged cells with cells that are tougher, more resistant to acid. Those are the intestinal-like columnar cells. That's the metaplasia.
So it is like the esophagus is trying to evolve almost, to put in a lining that can actually handle the stomach acid better.
Exactly. That metaplasia is basically an adaptation, trying to cope with a hostile environment.
But there's a catch.
There's a catch. While these new cells are more acid resistant, they unfortunately carry this increased risk of further abnormal changes, specifically dysplasia, that precancerous stage, which can then, in some people, progress to adenocarcinoma over time.
Right. And if a pathologist looked at a biopsy under the microscope, what are the key things, the histological features we should remember?
Okay, histologically, you'd see that columnar epithelium. Looks like stomach or small intestine lining. But crucially, the key feature for confirming Barrett's with intestinal metaplasia is the presence of goblet cells.
Goblet cells.
Yeah, they're specialized cells that secrete mucus. Think of them like tiny mucus factories. Finding them is a hallmark of intestinal metaplasia.
Okay.
You might also see something called a brush border, tiny projections on the cell surface, another feature of intestinal cells.
Okay, so goblet cells are key, maybe a brush border too. Those are the microscopic things to recall. Now, we know Barrett's is linked to GORD symptoms, but what if someone comes in with similar complaints? What else could it be? Let's run through the differentials for revision.
Right, the what else could it be section, important stuff. If someone has heartburn, regurgitation, you need to think broader. One common thing is erosive esophagitis.
Okay.
Basically inflammation of the esophagus, maybe with erosions or ulcers in the lining. So there's damage, but not necessarily that specific change to intestinal type cells.
Okay, so inflammation, but not the Barrett cell type.
Precisely. Then you've got peptic strictures. These are narrowings of the esophagus, usually caused by scar tissue forming after chronic inflammation from reflux.
Makes sense. Scar tissue narrows a tube.
Exactly. Another important one is eosinophilic esophagitis. That's more of an inflammatory condition thought to be driven by an allergic reaction. You get a buildup of immune cells called eosinophils in the esophagus,
And that causes...
narrowing and difficulty swallowing often. So similar symptoms again.
Right.
And of course, you always have to consider esophageal cancer itself as a possibility, especially if there are more alarming symptoms, significant weight loss, persistent vomiting, worsening swallowing problems.
Yeah, the red flags. So it sounds like there's quite a bit of overlap in symptoms, which really underlines why you need that endoscopy and biopsy for a definitive diagnosis.
Absolutely crucial.
Now let's think about how common Barrett's actually is. What's the epidemiology, particularly here in the UK?
Okay, in the UK, the estimated prevalence, so how many people have it at any one time, is thought to be around 2 to 3% of the general adult population.
2 to 3%, okay.
Interestingly, some studies suggest the incidence, the rate of new cases, might actually be increasing, particularly in Scotland. And as we mentioned with risk factors, it's diagnosed more often in men and usually in people over 50.
And how does that UK figure compare globally?
There is a bit of variation worldwide. Partly because, as we'll discuss, Barrett's can be asymptomatic, so it often gets picked up incidentally during endoscopies for other reasons.
Right.
But generally, European studies tend to report prevalence around 1 to 2%. In the USA, estimates are a bit higher, maybe 5 to 6%.
Higher in the US. Interesting.
Yeah, and perhaps not surprisingly, the prevalence is much higher. Could be up to 15%, maybe even more in some studies in people who are already known to have GORD.
So having GORD really bumps up your chances of also having Barrett's.
Significantly, yes.
What about those demographic trends you mentioned earlier? Anything particularly memorable for revision there?
Yeah, so definitely more common in men, more common in people of Caucasian ethnicity. It seems relatively rare in individuals of African ancestry, and the prevalence clearly increases with age. Family history bumps up the risk too.
Okay.
But a particularly interesting UK-specific finding relates to age and gender patterns. It seems the prevalence in men increases quite steadily with age, say between 20 and 59. The striking thing is that women show a similar pattern of increasing prevalence with age, but it appears to be delayed by about 20 years.
Wow, a 20-year delay in women. That's definitely a specific factoid, potentially useful for exams.
Could be a good memory hook, yeah.
And you also mentioned earlier that it's likely more complex than just acid reflux causing the metaplasia.
That's right. While acid reflux is clearly the main trigger, the actual development of metaplasia is probably multifactorial. It likely involves a complex mix of genetic predisposition. Some people might just be more genetically wired to develop Barrett's in response to reflux, and various environmental factors that we don't fully understand yet. It's not just a simple equation of acid exposure equals Barrett's.
Okay, so genes and environment playing together. Now, how might Barrett's actually present clinically? What features might make a doctor suspect it?
This can be tricky, actually, because, as we've sort of hinted, Barrett's esophagus itself often doesn't cause any specific symptoms.
Really? Not at all.
Many people who have it are completely asymptomatic. They might only find out they have it if they have an endoscopy for a totally different reason.
So they could be walking around with it and have no idea.
Exactly.
Yeah.
However, because it's so strongly linked to GORD, patients with Barrett's very commonly report the symptoms of GORD.
Okay, so things like
Frequent heartburn, regurgitation, that feeling of stuff coming back up into the chest or mouth.
Yeah.
Maybe some chest pain, sometimes difficulty swallowing. Though difficulty swallowing could also point towards complications like a stricture or even cancer, so that needs careful assessment. But the key thing to remember for revision is that Barrett's itself doesn't typically add new or different symptoms on top of standard GORD symptoms.
That makes sense. It's more like a silent consequence of the long-term reflux rather than something with its own distinct warning signs. So how is it actually diagnosed then? What investigations are key?
The gold standard, without a doubt, is endoscopy with biopsy.
Okay.
So during the endoscopy, a flexible tube with a camera goes down the esophagus. The endoscopist looks at the lining. If they see areas that look abnormal, often described as looking more reddish, maybe velvety compared to the normal pale lining, they'll take multiple small tissue samples, biopsies.
And those go off to the lab.
Exactly. Sent to a pathologist who examines them under a microscope, looking specifically for those characteristic intestinal-like cells, the goblet cells, to confirm intestinal metaplasia.
So the endoscopy raises suspicion, but the biopsy confirms it.
Got it.
Are there any other tests involved sometimes?
Yeah, other tests might play a role occasionally. For instance, maybe a barium swallow and imaging test could show the structure, identify narrowings, but it won't diagnose Barrett's itself.
Right.
Esophageal pH monitoring can be used to actually measure how much acid reflux is happening and see if it correlates with symptoms.
Okay.
And crucially, for people diagnosed with Barrett's, regular surveillance endoscopies with biopsies become essential. That's for monitoring, looking for any early signs of dysplasia or cancer developing.
Right, the follow-up.
Exactly. And sometimes, if the first biopsies are a bit unclear, maybe they don't definitively show intestinal metaplasia, they might need a repeat endoscopy with more extensive biopsies later on to clarify things.
Okay, so endoscopy plus biopsy is the cornerstone for diagnosis, and then surveillance is key for monitoring. Let's move on to management then. How is Barrett's actually managed? What are the main strategies for exams?
Okay, management really has two main goals. First, control the underlying GRD effectively. Second, monitor closely for any signs of progression towards dysplasia or cancer. Generally, management involves a mix of things: lifestyle changes, medications, and sometimes endoscopic or even surgical procedures.
Right, let's bring those down. Lifestyle changes first, what's usually recommended.
The lifestyle advice pretty much mirrors what you'd tell someone with GERD anyway.
So things like,
Achieving a healthy weight if needed, definitely stopping smoking, limiting alcohol, elevating the head of the bed can help with nighttime reflux, eating smaller meals, avoiding eating late at night, and also identifying and avoiding any personal trigger foods or drinks that seem to make their reflux worse.
standard GORD advice, basically. And what about medications?
Long-term treatment with proton pump inhibitors, PPIs, is really a cornerstone here,
Why PPIs?
because they're very effective at reducing stomach acid production. Less acid means less reflux, less damage to the esophagus, and hopefully less chance of progression.
Okay.
For some people who don't get enough relief with a standard once-a-day dose, sometimes a twice-daily dose might be needed.
Right. What about aspirin? You sometimes hear about aspirin for cancer prevention.
Good question. For your revision, remember, aspirin is not recommended for preventing Barrett's progressing to cancer. The evidence doesn't support it for this specific indication.
Okay, clear on that. PPIs are the main drug. Now, what about those more invasive options? Endoscopic treatments, surgery, when do they come in?
Well, endoscopic surveillance, as we said, is vital. How often depends on things like the length of the Barrett's segment and whether there's any dysplasia found.
So roughly.
For long segment Barrett's without dysplasia, maybe every 2 to 3 years. For short segment with confirmed intestinal metaplasia, perhaps every 3 to 5 years.
Okay.
But it's really tailored to the individual patient's overall risk, age, sex, family history, smoking, etc.
Makes sense.
And an important point: for short segment Barrett's less than 3 centimeters, where intestinal metaplasia hasn't been confirmed on at least 2 separate endoscopies, routine surveillance is generally not recommended.
Right, so you need that confirmed metaplasia for surveillance in short segments.
Exactly. And it's worth stressing again, finding high-grade dysplasia or very early cancer through this surveillance massively improves the chances of successful treatment. Early detection is key.
Absolutely. Now, what about actually treating things found during endoscopy? You mentioned eradication therapies.
Yes. If someone with Barrett's develops neoplasia, that means high-grade dysplasia or early-stage cancer that's still just in the lining, then endoscopic eradication therapy is often the way to go.
And that involves?
Techniques like endoscopic mucosal resection or EMR, that's where the abnormal tissue is sort of lifted and cut out,
Okay.
and also radiofrequency ablation, RFA. That uses controlled heat energy to basically destroy the abnormal Barrett's lining.
Ablation, burning it away.
Essentially, yes. There are other ablative methods too: photodynamic therapy, PDT, argon plasma coagulation, APC, lasers, but the evidence for their routine use can vary a bit. RFA and EMR are more established for dysplasia.
And what does nice guidance say about these?
NICE generally recommends endoscopic resection, so EMR, for any visible lumps or bumps or areas confirmed as high-grade dysplasia.
Okay.
For confirmed low-grade dysplasia, RFA is often the recommended approach. And if the dysplasia is sort of indefinite, the pathologist isn't sure if it's low or high grade, then usually it's close endoscopic follow-up with more biopsies.
Got it. And finally, surgery. Does anti-reflux surgery have a role?
Anti-reflux surgery, like a fund application.
Yeah, wrapping the stomach.
Exactly. It's generally not recommended specifically to prevent Barrett's progressing to cancer,
Okay.
but it might be considered for some patients mainly to control really troublesome GORD or dyspepsia symptoms that just aren't getting better with PPIs.
Right. So surgery is more for the reflex symptoms themselves, not directly for the Barrett's progression risk.
Okay.
Now, the big picture, what's the overall outlook? The prognosis for someone diagnosed with Barrett's.
Okay, prognosis. While having Barrett's definitely increases your lifetime risk of esophageal adenocarcinoma compared to someone without it, it's really, really important to stress that the vast majority of patients with Barrett's will not develop cancer. They're much more likely to die from something else entirely unrelated.
Okay. That's reassuring. What sort of numbers are we talking about?
The estimates vary a bit, but roughly maybe 5 to 10% of people with Barrett's might develop adenocarcinoma over a period of maybe 10 to 20 years.
So it's a relatively low percentage over quite a long time. The increased risk is real, but it's not like it's inevitable.
Not at all, exactly.
Yeah.
And that's why the regular surveillance is so crucial. It allows us to pick up any high-grade dysplasia or very early cancer when treatment is much more likely to be curative.
Right. What about screening then? Should everyone with chronic heartburn just get screened for Barrett's?
That's a really key question, both for public health and for your exams. While chronic heartburn is a symptom linked to increased cancer risk at a population level, the absolute risk for any one individual patient is still pretty low. So, routine, widespread endoscopic screening for Barrett's in everyone who just has reflux symptoms. It's generally not considered cost-effective or clinically justified.
Okay, so no mass screening for heartburn sufferers, but are there specific groups where screening might be considered?
Yes, exactly. Targeted screening. It might be considered for people with long-standing frequent GORD who also have multiple other risk factors.
Like the progo race factor.
Like the Brogo race factors, yes. Age 50 plus, white race, male, obesity. If someone ticks several of those boxes and has chronic GORD, screening might be discussed. And the threshold might be lower if there's a strong family history of Barrett's or esophageal cancer in close relatives.
Okay, focusing screening on the highest risk groups. Makes sense. Finally then, let's just summarize the potential problems, the complications that can arise with Barrett's.
The main complications really center around that risk of developing dysplasia, which, as we know, can progress to adenocarcinoma.
Right, the cancer risk is the big one.
It is. But other things can happen too. Bleeding, for instance, maybe from ulcers or erosions within the Barrett segment.
Yeah.
And strictures can form those narrowings, causing difficulty swallowing.
Okay.
But yeah, the most clinically significant complication is definitely the adenocarcinoma risk. And that risk is influenced by things like age and how long the Barrett segment is.
Can you give us any rough figures on those risks? Just for perspective.
Sure. Studies suggest the risk of developing some degree of dysplasia, mild to severe, in patients with Barrett's might range from around 2% up to maybe 25% over several years.
Okay.
The estimated overall lifetime risk of getting adenocarcinoma if you have Barrett's is roughly 3% for women, maybe 5% for men.
It's still relatively low lifetime risk overall.
Yes. But, and this is important, if someone does develop high-grade dysplasia, their risk of it progressing to invasive cancer within the next 5 years is quite high, often quoted around 40 to 50%.
Wow. Okay, so catching it at the high-grade dysplasia stage is really critical.
Absolutely critical. That's where interventions like ablation can make a huge difference.
Right. So let's try and bring this all together. What are the absolute key takeaways about Barrett's esophagus for MSRA revision? The must-know points.
Okay, the essentials. Barrett's is that change in the esophageal lining squamous to columnar with intestinal metaplasia, strongly linked to chronic reflux, carries an increased risk of adenocarcinoma.
Good.
But crucial points, most people with reflux don't get Barrett's, and most people with Barrett's don't get cancer.
Right.
Regular endoscopic surveillance and management strategies are key for monitoring and early treatment if needed. Remember the Go, Race, Mnemonic for risk factors that's high yield.
Definitely.
And always think about the differentials when someone presents with reflux symptoms.
Spot on. And, thinking about that UK data, the rising incidence maybe in Scotland, that 20-year delay pattern in women, it really makes you think, doesn't it? How much more there is to learn about the mix of environment and genetics driving this whole thing.
Absolutely. Lots still to understand. Definitely food for thought beyond the exam.
Indeed. And of course, for those of you revising for the MSRA and looking for more great resources.
Yeah, don't forget to check out passthemsra.com.
And freemoussra.com as well. Lots of good stuff there.
Definitely worth a look.
Okay, that's all for this deep dive into Barrett's esophagus. Thanks for joining us.